For a modern approach of polycythemia vera, I believe it is very important, first of all, to recognize that polycythemia vera is not a benign disease, but it is associated with a reduced overall survival. So it is important to acknowledge that particularly young adults carry the most disproportionate burden as they carry a cumulative risk of thrombosis and complications, and also the overload of the psychological consequences of a cancer diagnosis. When we approach in a modern way polycythemia vera, it is important to move from a binary thrombotic risk classification, which is, as you know, is based on previous thrombosis and age, to a multidimensional evaluation of the patients, taking into account, for example, emerging biomarkers associated with thrombosis, like the JAK2 VAF and the neutrophil to lymphocyte ratio, but also integrating patients' goals, comorbidities, and compliance capacity. The current treatment for polycythemia vera accounts for conventional cytoreduction, mainly hydroxyurea, but we can move forward using interferons and ruxolitinib. Ruxolitinib particularly is approved in the second line after hydroxyurea failure, and it is particularly potent drug in reducing the splenomegaly and the symptoms, and also in reducing the VAF of the JAK2 mutations. And when we talk about interferon, we must acknowledge that dropeg interferon is FDA and EMA approved for PV, and in the long term it shows a very high complete hematologic and molecular response rates. And these molecular response rates correlates with an improved event-free survival. So we have kind of evidence that improving the molecular response also serves as a surrogate endpoint for outcome for PV patients. And then we can also move forward, including new targets for treatment, and this includes iron metabolism modifier, which are a very exciting field of exploration in polycythemia vera, and epigenetic drugs like mobedenstat and givinostat. So this is the future of PV.